Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. If you'll move to the first update. So for those of you who've been coming a lot this spring, you'll know that CMS had paused all of the no surprises independent dispute resolution determinations after a lawsuit, and they have slowly been resuming portions of that. And this past week, they have basically said, go ahead, everything's free to continue under the normal process. And so any services that any determinations that have been paused prior to the final decision, or anything that was is currently making its way through the system and hasn't reached there, will be able to proceed through completion of the dispute process. And there's a little notice at the top of this CMS page about it. They don't say much more than I just said, but feel free to follow that if you'd like to see that little bit more, or more information about IDR in general. Any comments or questions or thoughts there? All right, then let's move on to the next one. So this was interesting. Excuse me. ONC highlighted a JAMA study. That's the journal, I believe, Journal of the American Medical Association. I hope I got that right. That had done a 8,000 patient survey with data from April 2021 to April 2022, where they talked about information preferences for lab results. And what they found was basically 95% of all patients that they talked to, and this is at 4 major academic medical centers. So basically 95% of all patients wanted lab results immediately, whether or not those results were abnormal, and whether or not they saw those results before their doctors or other providers did. And what they also found, which was interesting, was that even with patients who got abnormal results, they were less worried after seeing the results than before seeing them. So even if it was bad news, just having the information was sort of a relief. And knowing what they were dealing with was a relief, and they just having that as soon as possible was helpful. What they did not look at, and they mentioned specifically, was how many or how well patients understood the lab data without getting interpretation from someone else. And they did say that 57% of people indicated that they sought out some type of additional information. Now, only a portion of those was actually trying to speak to their clinician. They also did, this also includes things like Google searches of terminology, or Google searches of expectations of, what a normal level is, or stuff like that. So I thought it was interesting. And as you can, the fact that there was no change between the different groups, the way they group patients, I thought was really the key takeaway from this. So you can find the blog post there. It links to the full study in the journal. And anyone want to comment or have any thoughts about this?
Dennis, was there any comment or context? I guess when you ask that question, the context of being frustrated historically by the lack of timeliness of getting results, at least I have to wonder whether or not, if people's historical experience had been that they always get the results quickly, and that the minute an abnormal result comes through, they get a phone call or a request from a clinician to talk, whether or not people might feel differently. If, drilling into, obviously if someone has results that are normal or fine, then, just getting that little, I get, the patient gateway from Partners pops up, and you look and you go, oh, that's cool, right? But isn't isn't the real question that if someone does have an abnormal result, the standard practice should be they get an outreach very quickly from a clinician that can provide the context immediately. I guess these results kind of don't really touch into any of what's good practice, right? Versus
there was some discussion in the blog piece about how there, so they didn't highlight this issue and provide data about what percentage of people were used to getting that type of outreach versus not. But what they did say was that there was a recommendation that there be some pre-planning, and that pre-planning definitely was helpful. And what that pre-planning included was an indication from the person doing the ordering that, don't worry, I will reach out to you after I get the results. So I don't know that there wasn't any specific data around it, but there definitely was sort of there's a good practice recommendation that this be part of the process.
Yeah, that sounds appropriate, because I mean, JAMA is for clinicians. So it strikes me that the real value of the study is to give data to clinicians who object to releasing patient results directly, right?
I would say that is almost certainly why ONC highlighted it.
Yeah, okay. Because it strikes me that it's not necessarily great data to talk about how should patients get the results.
Right. No, I think it absolutely is sort of aimed at those clinicians that are resistant to the idea of making the data available as quickly as possible. And so, and then, it definitely provides some data to back up the idea that it is helpful to send it immediately. But they did, again, follow up with that recommendation, as I mentioned.
Thank you.
Yep. Anyone else want to comment or have any thoughts on this?
I would just add to the prior comment that the variability in not only timeliness, but the engagement that a clinician will seek with a patient in discussing lab results, especially ones that are abnormal, may be such that getting the information first by having it directly available to a patient may in some ways be preferred, given that it's unclear how well clinicians, some who may do it very well, some who may not, can provide this information to patients themselves. Timeliness, assuming that they do it on time. I think that would be an interesting study. I agree with the question or the points that were made with respect to this informing the importance of timeliness. And the result of having, if timeliness were not an issue, how people would like to hear about this would be asking a different question than what this study addressed, but good information.
Yep. Yeah, no, I agree. And it was very clear that it was, there definitely were some portion of people who were not getting that outreach, who were then getting the results to extend the outreach themselves, because some portion of that 57% were reaching back out to their clinician saying, hey, I got this result, what's next? Or let's have a conversation about it, or what do I do now? So, all right, anyone else want to comment, or then let's move on. So I went to the TUFCA monthly update yesterday, and it was very interesting because it was a little bit more fire focused than they often are. There were kind of two big things that came out of it. Excuse me. So the first one is that sometime next week, most likely, it's possible it'll be later this week, but most likely next week, there's going to be a payment and healthcare operations standard operating procedure for TUFCA. And one thing that they talked about was that the healthcare operations definition for TUFCA will be narrower than HIPAA. I don't have any specific details about that, but that'll be one thing to look at when the SOP comes out. And they also were very clear that responding to healthcare operations requests via TUFCA will be encouraged, but it will be optional until FHIR is supported. There is an intent, once FHIR is supported in some type of real way, to move some of these things to be some of the stuff that they're going to make optional now will become required. Part of the fire support will be that they will update once they feel like there's a reasonable amount of fire support. They're going to update all of the SOPs in various ways to accommodate fire. They are starting some very limited testing of fire in May. Once they have started doing some testing, they will allow, excuse me, some of the QHINs to consider voluntarily supporting fire. This will have a wide glide path before they say they support fire, which is a lot of additional testing on the QHIN's part, including sort of a step-by-step, several-step process, starting with conformance testing that the QHIN itself is adequately supporting fire to a level that they consider acceptable, which, as you'll see from a later bullet, is basically US core support. Then there will need to be some testing of QHIN to QHIN exchange via fire. And then they'll allow some limited amount of going live. It wasn't clear exactly how that will be managed. I'm not sure they're sure how that will be managed because this is still pretty far off in the distance. But they're starting to come up with some specific ideas and plans on how they're going to do this. So as I've just mentioned, I asked a bunch of questions and they answered several of them actually. The initial fire support will only require compliance with US core. As time goes on and they start looking at more complete and moving towards real fire support in TEFCA, they will likely require either first optionally add and then require support for additional implementation guides that map to some of the specific allowed exchange purposes. One thing that came up, there was some inconsistent messaging, and I'm not sure if this is because different people have different thoughts about what's going to happen, or if they have multiple paths that they weren't explaining well, but there were some, at one point, they casually mentioned that one of the goals of their fire support will be supporting the CMS APIs. So basically that would mean that participants in the QHIN would be able to exchange data via fire and basically get data that originates from another participant via the fire APIs. That would include third-party apps using the app access exchange purpose, which IAS, I don't remember what that stands for off the top of my head, as well as payers and providers who wanted to use the various allowed payer to provider, payer to payer, provider to payer type exchanges. They did not go into any detail there. They just mentioned that that was part of the goal, but a different part, which I talked about in a little bit more detail, actually specifically said that the fire support they're aiming for was QHIN to QHIN, and that in order to say they support fire, the requirement was that they can exchange fire with other QHINs, but the participants would be allowed to use every other method under the sun, and there would be no requirement for fire support with participants. So that's something that still needs to be ironed out. They did make one attempt to clarify that a bit, but it didn't actually help that much. So as time goes on and they start actually moving a little bit further towards fire support, I think that's one area to keep in touch. The last thing that they talked about, which is worth noting, is that they are working on a public health exchange purpose, but they're not doing that with public input. They're doing that solely with public health agencies. And so they're not, it's not clear. In fact, they specifically said they won't have comments. They won't be allowing public comment for documents that they're working on now. There may be something in the future that will result in actual SOPs that they might open for public comment, but it sounded like that was pretty far off. So that's kind of the takeaway from the TUFCA update. It was a good update. It was a more informative update than they often are. That's not fair. It covered more things that I think we find interesting than they sometimes do. It's probably a better way to phrase that. Does anyone have any comments or questions or thoughts?
Hi, Janice, was there, so this is just still scratching my head on this whole Sequoia TEFCA thing that, I mean, early on, a lot of the payers gave the feedback to ONC, in the TEFCA definitions and final documents, that if you have working directories and APIs as defined under the FHIR protocols, by Da Vinci, by Argonauts, by, all of the accelerators, by Karen, you don't need a QHIN, right? You don't need.
That's right.
We work really hard in this state to get away from having to have clearinghouses in the middle, right? People can talk directly to each other with the 21st century technology. And so, was there any conversation at all, or are they just ignoring that? I mean, when I hear you make a comment that they're looking for public health use cases without involving the public, that just seems so consistent with, kind of the approach they've taken to this all along.
Yeah, that's actually a really good question. The TUFCA, we agree with a lot of what you're saying about TUFCA, and it's also very provider to provider focused at the moment. And I think that what happened is they got a lot of pressure from other parties to support these other use cases and to move from being solely CCDA focused to having FHIR support. But FHIR support was not part of the initial TUFCA plan as it was released. It was basically foisted on them by people who are like, how can you do this at this point in time without supporting FHIR? And so I think one of the things that's happening is there's this kind of push-pull between, let's just do the next version of an HIE that kind of makes that better, makes that more national and expands that, versus this group of people who want TUFCA to fit in with the stuff that's happening more generally, the changes, the CMS regulations, FHIR, use of implementation guides, et cetera. And I think that there's some churn at the moment around exactly how to do that. And they're making some attempt to kind of morph those two worlds together. And it's not, and TEFCA is one of those things where and Denny can speak more about this in a moment if he'd like to, but we're kind of like, well, let's see what happens and how it ends up actually getting implemented. It's also farther away than it probably needs to be useful for a lot of these things. So it's moving along in kind of a more traditional healthcare model with some people trying to pull it a little bit more into the modern view of the world, kicking and screaming. And so they're making these sort of forays off in that direction too. I don't know, Denny, if you'd like to comment.
Yeah, I think these efforts to make or to encourage or persuade or use TEFCA for reasons beyond its initial purpose are more likely to compromise TEFCA's effectiveness in the narrow domain for which it was originally intended. I think AHIP has discussed using TEFCA for payer-to-payer exchange, which seems like going all the way around the world to get to the house next door, going the back route. There are other discussions about health plan participation, about uses of FHIR with TEFCA, when I think the reality of TEFCA is we need to normalize the electronic medical record so that increasingly the electronic medical record is a more robust, less inconsistent, disparate collection of health data across thousands of organizations into something that looks reasonably aligned with respect to US CDI, with respect to standard protocols for exchanging data, which albeit are dated, but are what the industry is used to dealing with, namely the CCDA. But as people start piling use cases on top of TEFCA, because it looks like the elephant from their particular point of view, or they're experiencing a different part of the elephant and coming up with a different representation of it, I think that's a risk to TEFCA. I think, as a normalizer for clinical data in the electronic medical record, it makes good sense. I don't necessarily think it's the best way to do it, but I do think it makes sense at that level, and it's how the industry works today. Piling on new technologies and new use cases, I think compromises TEFCA's effectiveness at doing that core service. So we'll see how they respond. But if they keep taking these different use cases, different technologies, and mixing it in with what they originally started with, which is essentially, a quote unquote care everywhere type of model, a common format for electronic medical records to improve the quality of data and a mechanism for doing that, I think they're going to be much less effective. So we'll see, but that's my perspective.
Anyone else want to comment?
Just one quick comment, Janice, because I know we have to move on. This is Dave. I agree with what Danny's describing as sort of the focal point for TEFCA and the QHINs going forward. And what I would question around the FHIR, let's call it the FHIR adoption or the FHIR use within the QHIN model, is what are the use cases specifically for the FHIR capabilities that people are envisioning? What exactly is it going to be that people will be exchanging via FHIR versus what the CCDA standard does or doesn't allow today, that extends it to additional use cases that people are contemplating? FHIR for the sake of FHIR, to me, is just, it's kind of parochial. It's like, oh, you can raise your hand and say we're doing FHIR, but what are the specific use cases that are, more oriented toward a real-time exchange of data using FHIR resources with, with an API model of exchange, in presumably real time, I guess I would presume, but probably bulk FHIR would also be included in that. So what are those intended use cases would be my question.
Well, Dave, I think, if you look at the history, the technology underlying Sequoia, and I think we need to separate TEFCA from Sequoia. TEFCA, it goes back to when Mickey used to talk about HIE, the verb, and HIE, the noun, right? The activity of moving patient information ubiquitously in a fluid manner, in a dynamic way, in real time, so that important patient information flows wherever it needs to go quickly and easily.
Yep.
The underlying technology of TEFCA, the IHE protocols, were the original foundation. And, Dave, you probably remember, I was as big a fanboy of IHE as anybody back in the early IHE days, right? With the XDR protocols and all that, right?
Sure.
And then in 2014, a bunch of Nobel laureates told the feds, like, where have you guys been? The internet's been around 20 years. The internet moves information using APIs and using RESTful services, right? That these IHE protocols, the CCDA, they're totally inefficient, that they're never going to work. They're too expensive to implement. And so everything pivoted. The entire industry changed. Mickey was out there, trumpeting the Jason report that basically said we had to move to APIs. The feds embraced it, CMS embraced it. Everybody said those IHE protocols are dead. They're never going to work.
Yeah.
And then suddenly here we are, almost 15 years later, saying, oh no, we're going back to those IHE protocols and we'll only use FHIR where, the use cases happen to make sense. Well, all of the use cases for moving patient information using internet models, leave FHIR aside. It's using the internet to move information, because we live in a Google world. You ask a question, information pops up, you get your answer, and then you move on, right? That's the way the internet works. That's what FHIR is about. It's not about the FHIR standard. It's about APIs and RESTful services and moving patient information in real time. And so that's what continues to have me scratching my head. Why are we doing this? And in Massachusetts in particular, not to go off and pontificate here, if the local community with the backbone that exists already, with all the work that's been done with the local IHE, if the local community said, you know what, we're just going to have participants sit down, just like Nihan did 20 plus years ago, and said, we're going to figure out what's important to us. Let's move information. We've all got API and RESTful services at the edge of the enterprise. Let's just share what we need to locally. Let's not worry about, when a patient's in the EMR emergency room in San Francisco in, 1 out of a million use cases. Let's worry about what we need to do locally. To me, that's the use cases that I think you're asking about. Where does it make sense?
I that's exactly right, John. And then I'm asking, then how does TEFCA or QHINs or any of these other, sort of entities play a role in those local use cases? And I'm not sure that they
may
do.
not.
Yeah.
And I will also point out one other thing I think that's interesting to point out when you talk about this is, we keep also going back to the pain point of you're making me do the same stuff 6 different ways. And so if you're already sending your clinical data via FHIR for all these other use cases, then then sending it around in some other format using some other mechanism is actually an extra burden and not a help. So
and that's why when TEFCA was being published, I mean, AHIP has its own constituency, but the Blues Association, Aetna, Cigna, Humana, United, everyone, and they came out and said, look, we just invested billions of dollars under a mandate to put FHIR at the edge of our enterprise so we can connect to anybody we want. There's supposed to be a directory to let us discover APIs automatically. So why are you now telling us about this thing called TEFCA and Sequoia? This is just every major payer outside of AHIP spoke out and said this does not make sense. And so it's still got everybody, I think, thinking this is just, this is someone at the Feds telling us we still have to use horses and buggies when we've got, airplanes and cars and trains, right?
Yep.
Yeah. The challenge, I think, and I know we got to move on, Janice, but the challenge is that it was like the train had already left the station, on a lot of this HIE development work and the notion of QHINs and Care Anywhere, and, the various, entities that had invested so much in those sort of, let's call them legacy capabilities. That train had left and people are like, well, okay, but how are we going to just rip and replace all that? Are we going to forget that we ever started on that road? It's that kind of thing, I think, is where.
Yeah, well, I think that I also think that I know initially when they first started talking about TEFCA, and I'm not 100% sure, but I believe I heard Mickey say this as well. He was thinking of it as a bridge to some extent of we have the HIE model, let's make that more efficient and more effective, and then use that as a way to then morph that over to using FHIR for things. And I think the problem is that because it's using some of these older mechanisms and it's plan everything out in excruciating detail in advance, and standard operating procedures and agreements of that have to go national, that the rate at which TEFCA moves is so much slower than you can move with FHIR, that it's just not even an effective thought as something that you're doing as an interim step. And so I don't know how much thinking has morphed in from that perspective too, because those were comments I heard early on. But I think that it is definitely one of those things that it's keep an eye on it, see what happens, know that people are interested. I mean, CMS in the interoperability and prior auth rule that we just commented on was talking about looking at ways that TEFCA could be used to meet the world, to make the API, the FHIR API rules that they have more effective. And our comments were, we don't think that that's appropriate. Maybe at some point, when TEFCA actually has FHIR support, we can reassess whether that's still true. But I think that there is this kind of weird mishmash and sort of swerving of thought of where everything all fits together that hasn't been sorted out. And I think that we're just going to have to keep an eye on all of it. But I agree with one of the with the person who said that, you know, FHIR's been around for 20 APIs, RESTful APIs have been around forever, and it's the way everyone else does business, and it should be the way that healthcare does business too, for most things. All right, let's leave it at that. And move on to the next slide. If we'll pause here for a second. I hope you learned a lot from our quick updates and our lengthy discussion of TUFCA. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That email address is also on your screen.